we're going to describe the concept of tissue integrity. I think it's pretty self-explanatory, it means it's all intact, right? Notice when risk factors and impaired integrity, recognize when an individual has them. Okay, it's open, not good. Okay, provide appropriate nursing care, interventions, and evaluations. So, interrelated concepts. Everything can affect integrity. Every concept, every portion of our body can, in one way or another, affect our tissue integrity, or be related to it, or tissue integrity affects it, some way or another. Everything. Tissue integrity is structurally intact, physiologically functioning epithelial tissue, such as integrity. Hey, you know what? Most of this is going to be what we did in the lab last time, so we'll help you with this. Going over it again. Scope, intact as a protective barrier to some kind of a disruption or impaired surface. And it can be a bruise, it can be anything, scrape, surgical incision, anything. So how do we get impaired? Let's see, trauma, injury, and I just cut myself. Loss of perfusion. We see this with our PVD patients that have those dark purple, brown legs, and then their skin will split open. Immunological reactions, something you have a reaction to something. Infections and infestations, lice. You got infection, like we were just talking about, the last one. Thermal or radiation burns. What's the big thermal one everybody winds up with in the summertime? Sunburn. That is tissue integrity, right? Lesions, they caused by mostly cancer, right? Lesions. Okay. Oh, something new, right? Like you've never seen this? Same thing we did in the lab, the levels. So, the vasoconstriction, clot formation, that is your first stage. Inflammatory, remember this is when they're going to come in, the white knights are going to come in and clean it around, they're going to eat up the bad stuff. Somebody's going to be the dump truck and pull it away. They all have a purpose. Then the granulation and proliferation, 5 to 21 days, and then we're going to have our permanent scarring that can last for months to years. Sometimes it never goes away. Remember that? Do I need to go over that? No. Moving on. Remember that? All right, told you guys were going to get this. Okay, wound bed. We talked about this. Remember, your size matters. Because the only way you can know it's getting better is by keep measurements. If it's getting larger, it's not doing well. If it's getting smaller, we're doing well. Oh, somebody's leg was just talking about the leg. Looks just like it. Where'd she go? Where's Grace? Anyway, she had a patient that had a wound open. So, your primary is clean. It's going to be a very small scar. Your surgical incisions are primary intentional healing. You don't seek help. Will it heal? Will it close? Yeah, but it doesn't look too good, does it? And then these are wounds that are intentionally left open. Okay. Age-related conditions. We talked about this too. They don't have, their skin's thin, they don't hold on, they don't have fat, so they can't hold their heat in. Permeable skin, the child's skin is smooth, it's dry, it's how it should be. Adolescence, this is when the sweat glands start going in, the sebaceous glands is when that's why acne breaks out in teenagers, because this is all developing in them, overactive sometimes. And then adults, we get thin skin. I mean, we barely walk by something and it's going to turn into a bruise. The strength of the tissue is not as strong as it was when we were young. It tears easy. Less moisture is why we get wrinkles. It's not plump. So, what are the consequences of having some kind of integrity? Well, you're open to infection. You have impaired thermal regulation if it's a large enough area, which will come into play when we talk about the burns. Fluid and electrolytes imbalances, if you're losing enough fluid out of this open area, like with the burns, you can have an imbalance. Pain doesn't feel good. Little tiny paper cut, you think your finger's falling off, right? It hurts bad, but you got a lot of nerve endings there, so you're gonna feel it. So it depends on where the injury is, but you will experience some kind of pain. And then impaired body image, if it's a big enough scar, or a big enough area that won't cover up. All right. Conditions that's going to affect this. Poor peripheral perfusion. Are you gonna heal well? I think all 3 modules I hit this with you with perfusion. How important it is to the body and to the cells. You have malnutrition and obesity. You cannot heal through fat that does not have good blood supply. It is not gonna make it heal well. Dehydration or edema, if you have, anybody get tech that has seen the legs that just start oozing, start weeping? So much edema that it makes the skin split and the fluid just comes out of it. Yeah, so having long-term and a large amount of edema in the lower legs, they'll just split up and just start losing that. Fluid's gotta go somewhere. It's gotta go somewhere. And if it keeps building up, it's gonna burst. Impaired mobility. If you're not moving around, we talked about this with the pressure ulcers, right? And immunosuppressant, if you steroids, again, back to that steroid where that one is more susceptible to infection, it's an immunosuppressant. So it will suppress it. But so there are others too, especially your anti-rejection meds. A lot of your HIV meds are that way. They will cause issues with healing. Radiation. There's your sun radiation right there. Temperature extremes, frostbite. Tip of the noses fall off people when they're exposed for a long time. Chemical and mechanical trauma and medical treatment. Sometimes the treatment is as bad as the cure is as bad as the illness. And then tissue trauma. We talked about the shearing when you're moving them in the bed. Pressure ulcers, moisture, laying in bed sheets is not good for the bone. Okay, so how are we going to do this? Well, first thing we're going to do is we're going to assess our patient, so we need the general history. Do I need to go over all these again? Do you know how to assess your patient? Oh, I hope so. You got this far, you better know how to assess the patient. Okay, examination. I'm going to look at the color and the condition of the skin. Is it intact? Back to the infection, and what happens if it's not? Is there lesions? Do you see them? Maybe you might see a lesion on somebody's back that they don't even know is there. Make sure you're doing a thorough assessment on your patients. What does it look like? Is it raised? Is it flat? Is it oozing? Is it dry? Is it scaly? Is it whatever? You've got to describe this. Also palpation. Can you discover something underneath, like a cyst on somebody that may not be open or apparent? Like you might find one here. Touch on the arm. Pinch the skin for dirt. It's pretty good today. Some days it's bad. When you walk to work all day long, you drink. When you're a nurse, you're not lonely. You go like this and your skin will just stay up. You're like, oh, I need to go home and drink long water. Who's got time to pee? Okay, remember this? Stages of a pressure ulcer. 1, it doesn't break the skin. 2, the skin's broken. 3, it goes down into the lower levels of the dermis. 4, goes down to tissue and bone. Remember that? Okay. Assessing the wounds. Is this acute? Did this just happen? Or is this something that's a chronic? We have a lot of the patients that have peripheral artery disease and they have chronic wounds and it takes forever to heal them. Sometimes they have to go into the hyperbaric chamber and have forced oxygenation, high oxygen levels into the body to help them heal because they don't have good perfusion. We know how to measure, right? What is this? At this point, 12 o'clock. What are we doing? 3 o'clock. 6, 9. That's how we're going to describe where the wound is. Length, width, depth, you learned how to do that, you know the color, and you know the margin. Well, the margins, are they torn? Are they raggedy? Are they smooth? So that will be in your description of the wounds. Odor, are you smelling any of that wonderful seed or wounds on this? No, standard. It has an odor report. Okay, presence of wound band, we talked about the wound drainage systems in the lab. You can have a wound vac, you can have a JP drain in, you gotta document around that, you need to assess that site. It's a hole in the skin, right? Can we get infection in there? Percutaneous drains, they have flat ones that look like flat tubing, and they're real soft, and they're Penrose drains, and they're just up underneath the skin, it's just draining out. And exudate, describe it, the color, how much, is it purulent, is it green, is it yellow? So, what are we gonna do for these people? Well, number one, we're gonna change the dressing, and you've all been taught how to do that. Skin hygiene. When your tech is giving your patient a bath, you need to be in the room. You need to be in there helping them. Number one, you can feel the patient's skin. You can see the patient's skin. You can see the back of the patient, which you don't see when you walk into the room. You can see the bone, because that's where your pressure ulcers most likely are going to be. Be with them when they're doing the skin hygiene. Also, I know both of the big hospitals have lotion. Put them on your patients, they're laying in those beds. Are they losing moisture? They're laying against those sheets, and they're not moving and getting around. They need to be moist, very moist. Adequate nutrition. Dietitians can get in there and get you high calorie if they need it. They can bring in high protein diets if they need it. The biggest part is the food is not homemade. They hate it, it's not the thing. Sometimes you gotta just sit in there and talk with them while they're eating. I know that takes a lot of time, but sometimes it's just the company and the conversation, and they just eat because they're busy talking and listening to what you're saying. You just not even pay attention. How many times do you do that? You're watching TV, you just eat, right? You're not paying attention to what you're eating. Keep them company, perhaps. Burn safety, excessive sun exposure. Well, we need to teach using sunscreens, right? Burn safety precautions. Don't put your hand over the open flame. How hard is that to teach?
Tell a baby that.
We teach it to our kids, right? No, don't do that. We forget that as we're adults. As I have like numerous scars when I reach into the oven. Every Thanksgiving. Guaranteed. Dermal ulcer prevention, that is going to include turning the patients. Remember I said 30 minutes you can form an ulcer. You need to turn those who can't turn themselves. Fluff and puff. Fluff and puff. Okay. Pharmacology, they're going to help us. They're going to give us these goods and emollients, keep that skin supple. Antibiotics if we need to be treating something that is infected, and the smell will be there, most likely. Steroids. Be careful with the use of steroids. They need to be given at the same time. What can happen if you don't give them on time? It affects the adrenal function, right? Suppresses it. Could that then, when they aren't getting it on time, affect the rest of the body systems? The adrenals regulate just about every hormone in the body, don't they? Okay, chemotherapy agents. If you are giving chemotherapy to patients, you gotta protect you. They're very caustic. They will cause burns. You've got to be careful when you're giving them to your patients on regular floors. You give some you don't even know that are caustic. You know your meds. Read what it says. You need gloves. You open the package. you learned this in beads, or you learned it no bead. That is one of the phototherapies they do there. Billy Rubin. Do they use it to do what? They use it for what? Help break down the Billy Rubin, right? So the body, the sun would do that. Do they do that with patients, elderly patients too? They have used it. Excision debridement, debridements. We talked about that when I told you about the burn, right? They get in there and they scrape it away. They will do that with other ones too. When I showed you, we had that foot with the black ulcer on the eschar. They will debride that. They'll go in and they'll surgically remove it. Skin grafts. We talked about wound care in the lab. You know how to measure them. You know how to clean them, right? And the wet gauze on how to pack them to make them healthy. When we did the sterile, we talked about the sterile dressing. And nutritional support, especially protein. Can you rebuild muscle without your protein in your diet?
No.
A and D, they're good to help the skin knit back together. And C is good for everything. Wound care, initial and ongoing assessment. So I said you were assessing your pressure ulcers. Yes, all the time. When we were talking about the stages of them, and you need to watch because they're progressive within a day. And your shift that 1 can go to a 2 very quickly. Cleaning, you need to make sure that your patients are clean. Get that stool off of them. Stool will eat away at the skin. Make sure the exudate is cleaned out. Normal saline is great unless you have an order for, Dakin solution. Dakin solution is used on a lot of these hard to heal wounds that have bacteria in them. It's 1/4 bleach. All right, and then the dressings. You have regular gauze, you have regular dressings, you have occlusives. That's with your IV. Tegaderms, they're occlusive dressings. Semi-occlusives allows a lot more back and forth with the fluids and air. Hydrocolloid, that is the ones you're going to use mostly on your pressure ulcers on the bum. Hydrogel, alligate are used to help clean out some of that exudate and collagen and gooey stuff that's in your wounds. And then your VAPs. Burns. Yay. All right. So, how do we determine the amount of the body that is burned? Well, I will tell you that the Rule of Nines is done as a primary assessment in the beginning. It's not as fine-tuned as what the burn physicians will do when they get up to the unit. But for our quick assessment on patients, it's the Rule of Nines. You need to know the Rule of Nines. You will have scenarios that say your patient has burns on the front of this arm, the front of this leg, and half the chest. What do you got? You got half here, right? You got half here, and you got the front of the leg. So you got 9, 4 1/2, and half, which would be 4 1/2, and half would be 4 1/2. What do you got? Somebody figure it out.
18.
I just made it up in my head.
22.5.
That's too much mathing to go on here. But that's how you're going to figure out how, you got it, right? That is how they're going to say when the patient comes into the ED, oh my gosh, they've got this, 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 and this, and they're going to come up with the number, which you then saw how to figure out how much fluid, which we'll go into here in a minute. But Rule of Nines. So it's 9, 9, 9, 9 and 9 and 9 and 9, 9 and 9, 9 and 9 and 1. No No jokes, I don't wanna hear it. I didn't make it up, okay, there we go. So when they get up there, they'll use the pump, or the physicians will use it and come up with a more accurate number. But when they're first being treated, we're gonna use the nines to figure out how much we are going to infuse fluid, right? You did the practice. I haven't graded them all yet, so I don't know. Okay, so it's the patient's hand. Because that's in proportion to the rest of their body, right? They're not gonna have these little tiny hands in this 6'7" body. They're gonna have little hands. Does that make sense? So they can be mild. Some sunburns aren't mild, just saying, but yes. We can have superficial, which is just, sunburn can be a superficial. I had a small burn I had on my arm, it was superficial. It didn't go very deep, it's just the top layer. Partial thickness, the full thickness, and then if it's involving the bone, the tendons, and deep muscle, then it's gonna be the fourth. So. Bless you. Stay away, where's the mask? Kidding. Okay, we can have thermal, heat related. Yeah, or my arm and the other. That's fine. Chemical. Cleaning. Your cleaning detergents. Do you use gloves? When you don't use gloves, do your hands get, like, you feel like the top layer's not intact anymore? That's because it's literally burning your skin. Electrical burns can not show up on the outside of the body, but you have to follow the path of where it went. Like from here to here, and you might just see an exit and an entry wound, but you gotta think of all that tissue, bones, tendons that's been affected in between. Radiation, we purposely burn people with cancer, not when we give them radiation, right? It's targeted, because it destroys cells, just like the sunlight. It's usually just your top layer, but yes, it's still, radiation will destroy cells. And then inhalation, you may not even see any evidence of burn, but have them open their mouth, and it may be sooty black. And they inhale, so if it went in here, it's probably down into the lungs, or in the lungs, right? So you may always protect the airway of these patients, which we'll get to. So there's your scalp, your thermal injury. It can be top layer, hot liquids, steam. Cook spaghetti, you open up the lid, right? You take it in the noodles and it comes out and you get, yeah, all of us are cooking it like once or twice we've done it, or more. Flame, active flame. Contact, metal, tar, grease. You heat your grease up. You throw your fries in, and it splatters. It's hot, right? You get all these little specks, so you got these little tiny burns. It's all from the oil, right? I've done that. All of it. Now there's tar. Chemical can make it. This is going pretty deep. That is no longer topical, just from the sunburn. But strong acids, alkaline. If you leave soap on your skin, it will burn you. So it doesn't have to be acid. It can be an alkaline that will burn you if left over for a long time. Detergents, organic compounds, some of the solids used to take off the tar and stuff will burn. Priority is to neutralize it somehow. We want to change that pH back to as close as we can to normal. Remember, you only have that little window before damage happens. Necrosis underneath the tissue, and they need long-term irrigation therapy and wet to dry dressings or wound bags. Electrical. It looks like it was on cord for a while. I don't know what that is and how it happened, but it's caused by contact with electrical current. You need your entry versus your exit. That's how we're going to see where the half went, you're gonna be assessing that more frequently than anywhere else. The damage isn't always able to be seen, at least not always first. You need aggressive resuscitation, just like you do with a burn. And you need to be continuously cardiac monitoring. Why? Why would we do that?
Conduction.
Imagine that. We have electric, and we put extra electric in the body. Can we throw this electric off? Okay, oh yeah. And nobody told her to turn over, her 20 minutes was up on that side. And then external, they made radiation for maybe there's a tumor here or something, but it will make a burn on the skin. Inhalation, look at the mouth. You don't really see any burns on the mouth, but when you open it up, you can see it, so you need to protect their airway, get them, make sure, because this is swell. Injury, what did I say that happens when you have an injury? The body wants to flood that site to fix it. You flood this site, can you breathe? Protect the airway. So, direct thermal injury, inhalation of irritants, inhalation of chemicals. Like I said, I have reactive airways, inhaling that stuff forever. You might have some outer facial burns, maybe not. You can see soot if they've been in a house fire or a car fire. Singed facial hair, that's a good clue. I would know on him right away, wouldn't I? I mean, if it's all singed off and around, and then he's just got, I would know something to protect that area. Hoarse, they're talking, they sound scratchy. Perfusion, they're already losing their ability to give enough oxygen in. Upper airway edema is the earliest sign of inhalation and injury. Look for swelling in the tongue, the mucous membranes, the lips too. First thing you want to do is apply 100% oxygen, and then your ABCs go from there, airway, breathing, circulation. So carbon monoxide, that is considered an inhalation. It's not really a burn, it's an injury like the burn. When you're CO2, it's easier to carry the CO2 around than it is to carry around oxygen. Carbon, not CO2, CO. CO2's equal, they'll change with the oxygen density. But CO is easier than carbon monoxide. It's easier for the body to carry around, so it will keep it. It's easier. So, easy way to do. So it binds with your hemoglobin and will back up. Can it then pick up the oxygen? So you result in decreased arterial O2 hypoxemia, systemic and cerebral hypoxemia. You won't always see this though, you're not gonna know. They just come in and they're altered, or you know they've been in a place where they had a lot of carbon monoxide. We see this a lot up north in the winter time when they're using butane heaters or gas heaters. Anybody have gas heat here? So that's where you will see a lot of this, but they'll come in and you'll need to get them on 100% non-rebreather. They may intubate them right away. Excuse me. By forcing that much 100% oxygen. How much oxygen do you have in this?
21.
Yeah, roughly 21%, right? That's not gonna force the body to let go of that carbon monoxide. But you're putting nothing but 100% oxygen in there, it will. 100%. So the phases of the burn injury. So when we have the resuscitative phase, emergency, this is what happens in the first 24 to 48 hours. Our main goal for the burn is to protect the airway, restore perfusion, get thermoregulation on them. They're going to be losing, not so much with the electrical or with the carbon monoxide, but with the other burns, their skin's open. Can they regulate that temperature well? No. What else are they losing? Fluids. Yeah, they're losing a lot of fluids. So we need to provide emotional support for them. They need it a lot. Because number one, they're scared to death. They don't know what's happening. So, okay, so then in the acute phase, which is after the first 24, 48 hours and goes to the third day, that's when the wound starts to, they diurese, when they start pulling. Management, cardiopulmonary support. We want to prevent hypotension because we want to make sure that they have enough circulation and perfusion to help heal. We want to make sure they're getting enough food and enough calories. Burn hose. Tell them, what's the calories? What are they doing for the burns? My peeps. You, go on, speak up. We're doing burn shakes. Up on the trauma burn unit, they used to have these contests to see who could come up with the best tasting burn shake. And they'd have people come in and vote on it because they give this to these patients every day, several times a day. They need the additional calories, the additional fluids, but they need to get that in there so that their tissue can heal. Extra calories, lots of extra protein. Wound care, of course, pain control. And I did tell you all about how much they need that pain control when they're in there scraping those wounds. Didn't know this was all going to come so handy, right? That lab. Imagine that. Sort of was like a plane. Psychosocial. Again, they need the support, especially those that are severely burned, because they get very, very depressed. Into the rehabilitative phase. This extends past the hospitalization to long-term acute care or nursing home if they're never going to be able to take care of themselves again, which we have seen just recently. Function, they want to make sure that they get as much functional ability back for these patients, which is why they scrape those wounds so that they can keep movement as much as possible. Recovery may last years, may last a lifetime. They may never ever get back because it's hard for the body to replicate what was first there. It doesn't repair well. The scars are stronger because they've been injured and they're hard to move. You lose flexibility. So, history, how did it happen? Were they deep frying a turkey outside? Thanksgiving, we see a lot out of burns. Icing in the hot oil. No bueno. Just saying. Get the age, weight, and height. We need the age, we need the weight for sure, but we're going to figure out how much food we're going to give them. Full health history. What's going on with you? Is there certain things that are going to prevent them from healing well? Allergies, medications, have they been immunized? They're going to be worried because they have all this open area that tissue integrity, and we talked about infection, it's the first defense. Other injuries that may have taken place in the burn. Maybe they've got a broken leg now, or they were in a car wreck and it caught fire, we've seen that, and have other injuries, or they flung the can and they hit them in the head. I don't know. Well, you never know what happens. We had one that was smoking on oxygen. And then fell back out of the chair. You never know. So, respiratory, we want to make sure that we are, that should be frequently for respiratory, because if they're going into septic shock, you will know. If they have had infection set in, you will know. Your respiratory rate will change. It is so important to be an accurate count. Skin, again, with the total burn surface area, they'll do it with the palm. You're going to frequently, they'll be reassessing all of those sites of the burn. They won't reassess the amount of percent, but they're gonna keep you referring back to that TBSA. So you need to know what that is when you're taking care of these patients. Laboratory, drug and alcohol, do you think there's a lot of those that occur and have high alcohol levels? And then eyes, especially if they're smoke inhalation, they need to have an ophthalmic assessment, especially with CO too, with CO also. That's it. Superficial, first degree, only the epidermis. May go into to the second degree after it blisters and starts peeling. You ever had that sunburn that bad? You're peeling like, I mean, it's just like blisters and then blisters and more blisters. Not good, that's up into the second degree. Second degree partial burn, we're gonna go deeper past the initial first layer. The skin appears less moist, there's less pain involved. Are you burning off some of the nerve endings in there? That's why it's less pain. May have some moderate edema forming. You may have some eschar present where you have that black tissue that you can't see what's underneath it. Maybe, maybe not. Might need some surgical debridement, but it may only need to have the wet to dry dressings to pull off that little bit of eschar that will come off with being damp and wet and moist. Scar, you will have scarring. You go into the third degree, the entire skin dermis layer is gone. You're going right into the fat layer. Appearance is yellow. Yellow would be the fat. You're seeing the fat there. It might be red because you're having some blood there. You can have the black eschar. Brown fat. We have brown fat, right? You know that brown and white fat. It can be dry and very painful because you're going past that initial skin, into the fat, and then you're starting to get a little bit laid down into the next layer where you're not quite into the muscle, but where the nerve endings are. Does that make sense? So they'll start feeling more pain with this one than they would with the second degree. May have some contractures depending on where the scar is. I talked about how if it's down here in the elbow there and it's not constantly taken care of, they may freeze it. They may never be able to bend it again because the scar tissue is so thick. They can't get past it. It can take months to heal. So the fourth degree, you're going to look down and see tendon. You're going to see bone, deep muscle. They're bad. They're real bad. The damage. It'll be black, severe edema. They'll be oozing fluid constantly. They'll be in severe pain surrounding the area. Where the area is itself, they will not have it, but it'll be surrounding the area. Eschar will be present. They cannot graft them if they're in the fourth. They can't graft because there's no healthy tissue underneath to attach it to. There's nothing there. So they just have to let it heal. All right. So, superficial. There you go. Just the top layer, barely there. Deep partial, that would be your second degree. And it's, sorry, that's just the tendons and the bone. Full all the way down. Now they can't, there's no healthy tissue to graft over this, is there? Some of this will cover up, but interventions. Airway maintenance. We want to make sure that we maintain their airway at all times because you never know whether it has affected the larynx, the mouth, or down into the upper airway, lower airway. Optimized perfusion. We want to make sure that we have enough fluid circulating in them. Don't let them become hypervolemic. We want to make sure that we are controlling their pain. They'll be more compliant with you in taking care of them if they're having, you're not gonna get, if they're that bad, you're not gonna get rid of the pain. But we want to make it to where we can do what we need to do on them. And that's torture and you're scraping all that stuff off. Infection control is big on these patients when they're doing the dressings. It's all done with gowns and masks and gloves, and it's all sterile. And you turn the heat way up because as you're uncovering them, they start losing all that body heat. Thermal regulation because there's no skin holding it in. Wound healing, they'll be keeping measurements on them. They often take pictures and measure through a certain amount of time depending on how bad the burn is. And then again, nutrition, make sure we're getting those high protein shakes into them so that they can eat. Now, if they're intubated and we're doing these, they'll have them on the TPN or a high calorie NG feeding tube. Feed, high protein, high calorie. So some of the medications that we'll use for pain for these. Analgesics, lots of them. So they'll use IV during emergent acute phases. They'll have a PCA if it's severe and they're still cognizant and able to push it themselves. They can put them on a PCA that's a basal dose running when they're not. When they are able to be cognizant to push the button, they'll give them a second dose of boluses. Morphine, they'll give them fentanyl. NSAIDs, kind of hard to get with. There's a fine balance with using the NSAIDs with them because it can cause inflammation. I mean, NSAIDs and it's sodium based, right? So will it hold water, cause more edema? I can take them to my feet swell when I came home because it brings edema. So you gotta be careful when they're using the NSAIDs. Most of the time they'll stick with the morphine. And they will give these benzodiazepines just as an adjuvant to it. They will help. If you're helping the anxiety, they're going to experience less pain. Even though they may have the same level of pain, they themselves will perceive it as being less. So often they give them Ativan with the morphine when they're doing these dressing changes. Oh, right there. Role of anxiety and pain. Effective sleep deprivation. Do you think they're sleeping well? If they're not sleeping well, are they perceiving pain to be more? Do they want to give them sleep agents? You know, Restoril or whatever else they're using nowadays. I don't even know what they're using to help them sleep. Benadryl a lot of the times. So yeah, they want them to get the rest because they will heal better. Non-pharmacological distraction. Talk to them. Have them talk to you. Tell you a story if you can. Hypnosis, I've never seen it done, but they say it does work in guided imagery. And humor. Make them laugh. Laughter's the best medicine. It really is. Because that not only distracts them, but gives you some funny imagery when you're telling them dumb stories. So, nutritional support, I talked about that. You need high nutrition with stress response. What happens, the fight or flight? Are you using up calories just because you're stressed? Yes. So hypermetabolism, because the body is going to try and heal that skin as fast as it can. It usually can't do it by itself, but it does want to try. So it burns up a lot of the calories. So you want a high calorie, high protein. They'll provide supplements if they're eating. If the burns aren't, affecting the mouth where they don't have tubes and they can't swallow or whatever, they'll give them supplements to drink with their food. They let them eat. Give them, let them choose their food. Give them a certain amount of calorie, caloric intake, and then they'll give them shakes on top of it. Anabolic steroids, again, you run that risk of it suppressing the system. That may leave them susceptible to an infection. You do that type walk with medicines with patients all the time. And beta blockers to prevent that fight or flight, catecholamine response. Do you want their heart rate to go up? You don't want to keep it steady. You don't want it to be spiking up high. Enteral feeds, maybe to supplement the caloric needs. And then with your patients that are intubated or cannot swallow on their cells, cannot eat, you'll go to the small bore feeding tubes postpartum. Those are very residual checks. Okay. Or you did this one for your entry in, right? Hartman formula. So, when you're figuring this out, first one. And some asked me to go over it here. So I'm gonna need somebody with a calculator while I'm writing. Okay? She's right there. She just threw you under the bus. I love it. Okay, so we had 198 pounds, right? What's that come to kilograms? 90? Wow, that was good. I didn't make this up, so 90 kgs. So it was ordered to use the 2 milliliter formula, right? So we have 2 milliliters times 90 kgs, and how much was the burn? Times 65. And that gives me a total. So, how much, that's our total, that's how much we need to give them for the first 24 hours, right? Now, how much are we gonna give in the first 8 hours? Half of that. So you divide it by 2, and you get 5, 8. That's what we're giving in the first 8 hours. So that leaves us how much left? Well, if this is half, that means we still have that much left, right? Okay, so we have 5, 8, 5, left to go over how long? 16 hours. So, if I'm going to divide that in half for the next 8 hours, correct? Make sense? So that gives me 2,875. No, half of this. 2,925 for the next 8 hours. For the next 8 hours. And then 2,925 for the third 8 hours. And that gives you your 11,700. Yes? Did we get that? Okay. That's the Parkland formula. Do we understand it? Do I have questions on it? Okay. All right.